Hi, Randy Alvarez here. You're listening to the Randy Alvarez podcast, and today is a big topic, which is stem cells. So, look, I've been interviewing medical doctors for more than 22 years, all over the United States and outside of the United States. And when the topic of stem cell came up, I thought, okay, so who knows a lot about stem cells? Who's not just studying it, but a practitioner using stem cells in their daily life, daily practice, who could give us kind of the medical down low, the inside scoop when it comes to stem cells. And the name came up, Dr. Matthew Ranson. And to just to give you a little bit of a bio, I mean, he is a top-ranked interventional spine and pain management specialist and anesthesiologist. He has a huge following. We've had him on the television show before, and that's how I met him. And with interventional pain, you know, these guys, at least this is what they told me, they're trying to avoid drugs and surgery at all costs. Dr. Ranson, welcome to the podcast. How are you?
Good. Good morning, Randy. Thanks for having me again. So, as you know, just before we get started, I don't like the word stem cell therapy. We've talked about this numerous times. You know that.
Is it because it gets you in trouble? You're not allowed to say it?
Well, I think it's making promises that we don't know that we can keep. When you say stem cell therapy, you are telling patients and the consumers that we're actually putting stem cells in their body, either from their own body or from a donated source, and that these stem cells are going to incorporate in the structures and heal them. That's the claim that you're making when you say stem cell therapy, and I think that's why the FDA has come down on so many people for using that term. So I prefer to call it regenerative therapy.
Okay, could we start, though, the podcast? I want people kind of hook them in right off the bat. Stem cell therapy, when done properly, the kind of stem cell we're talking about today, with the indicated person, that it's really working. People that were in pain are out of pain. People maybe that were scheduled for surgery are maybe postponing their surgery. People are anecdotally, clinically, are saying their neck that they've had problems forever is going away. They're back on the tennis court because of these stem cell injections. Is that true?
That is true. Yeah. But again, I like to call it regenerative therapy. So we can
we'll
delve
call
into
it that today, regenerative therapy.
Correct.
Can you give us a working definition of regenerative therapy? Is it just stem cells or is it other combination therapy?
Well, you know, most of the leading scientists, and I have a molecular biology background before I went to medical school, most of us are a little hesitant to say that, as I mentioned earlier, that the stem cells are actually incorporating in the structures. You have to look at what's in these so-called stem cell preparations, either be it from your own body or from a donated source. And there's a lot more than just cells. And in many cases, and we'll talk about this a little later, some of these preparations are acellular, meaning they've been treated with radiation to remove any living cells, and there are reasons for that. And yet we're still seeing magnificent results with these regenerative therapies. So what is causing the healing of the tissue, the restoration of function?
Before we go into that, because the mechanism is the least of our worries at the moment, at the beginning. What I want to do is, what areas treat the best for stem cell therapy? And maybe we can start from the neck and go down. And we're going to talk in terms of pain and spine, I guess, and knees and joints and shoulders and things like that. So what are the areas that you treat typically?
So I treat the entire musculoskeletal system. That's what I treat. I don't delve into treating COPD and things like that, because that's really off the reservation, so to speak. So conditions that I treat would be like cervical radiculopathy, where you have neck pain in conjunction with pain going down your arms. Same thing with musculoskeletal disorders and say in the shoulders. You can put these regenerative products in the shoulders and sometimes avoid a shoulder replacement or heal a partially torn rotator cuff injury. You can go down the thoracic spine, same thing. You can treat what we call internal disc disruption, where you have damage to the disc that causes significant pain. Sometimes that doesn't radiate anywhere. It's just really functionally incapacitating. And then as you move down the lumbar spine, same thing. We can treat the disc. We can treat radicular.
When you say that you could treat the disc, like what kind of condition is the disc in? Does it puff it up a little bit more, or what does it do to the disc?
Yeah, that's an interesting question. So, you know, younger patients, say 60 and under, maybe 18 to 60, they typically, the ones that present with, say, low back pain, they have what's called internal disc disruption many times. And this accounts for maybe 40 or 50% of people with low back pain. And it's the disc that's damaged. And so what does that mean? Well, you can have a herniation, but in many of the cases, you know, where the disc kind of expands outside beyond, you know, where it should normally be, many of the cases you just have what we call desiccated disc, and then the internal structures are disrupted. and that causes functional low back pain. And like I said, maybe 50% of people, upwards of 50% of people that have back pain, that's the culprit. And then less likely sources are the joints in the spine, the facet joints. Those also are very readily treatable with regenerative products. And then lastly, you're going to have, the patients that have radicular symptoms. That means pain radiating into their legs or arms. And that occurs from nerve irritation. Sometimes it's not from a herniated disc. Many times it's from leakage of the inflammatory cytokines and other chemicals that are found inside the disc. Those are very irritating when they get outside of the disc. And so just a little tear in the disc can cause leakage of these inflammatory molecules.
Which cause pain.
What's that?
Which cause pain.
Correct. Absolutely. So it depends on what your pain pattern is as to what we target. But all of these pathological conditions are readily treatable, not with surgery necessarily, but with regenerative products.
Regenerative products meaning products that are using either the body's stem cells or growth factors or actual stem cells. And I guess there's different types of sourcing of stem cells, which I want to ask you a lot about. But so with everything you just mentioned, so neck pain, pain going down the arms, have you had instances where you inject into the pain generator, into the area where they're getting the pain with stem cells, and their neck pain went away, their arm problems went away? Has that ever happened?
Absolutely. I've done more than 250, I quit counting at 250 procedures in the spine. Okay. And I would say this is all anecdotal. I haven't published any of this because you have to have an institutional review board and all this other stuff and funding from some rich pocket company to perform all these studies. But I've done about 250 plus spinal procedures, and I've treated everyone from 25-year-olds upwards to 80. One was 87, sorry. And about over 90% of them have had significant decreases in pain. Some of them are completely asymptomatic.
Okay, so for example, like 22 years ago, I interviewed this guy, I think it's Darrow, a lot of people know who he is, on prolotherapy. It was just, I guess, shoulder pain, injecting some solution, sugar water. I don't know what it was, saline. It was just basically, sugar water, injecting it. And people were saying their shoulder pain went away. And he was saying way back then that it's like growing tomatoes in a garden, that when you injure the area, the body does a kind of a crazy thing and brings, the growth factors and stem cells to the area to heal it. Now, that old version, is this just like a newer version that you guys have figured out that certain growth factors or stem cells or these cocktails you put together with a regenerative therapy, that it's so much better than this old style PRP or prolotherapy? Is it much better, much different?
Yeah, that's like regenerative therapy light, and now we are light years ahead with the products that we have available to us now. So I can walk you through kind of an overview of the evolution of regenerative so-called stem cell therapy, if you like.
Yeah, let's do it.
Yeah, so
I'm going to go off camera for just a second, but keep talking.
Sure.
I got to get some notes.
Sure, absolutely. So as you know, you mentioned prolotherapy. That was probably the earliest form of regenerative therapy, and what you're doing is you're causing a noxious insult to whatever structure you're trying to heal, and the body is then responding with growth factors and its own stem cells and repairing the structure. That was the idea behind doing that, and then
it worked, right? I mean, it was working. Was it a placebo or what was it?
Well, yeah, it may well have been. I mean, the evidence is pretty scant for prolotherapy, which is why most of us think it's kind of voodoo, witchcraft. Okay. But it was probably better than putting steroids in because, as we've talked about, previously, steroids are very toxic to your body. So then someone decided that using platelets, which have growth factors and other anti-inflammatory cytokines in them, from your blood, just draw some blood, spin it down, and extract the platelets. That may
is that what platelet-rich plasma is?
That's right.
So
Correct,
taking your blood, you spin it. It's got like growth factors, and then you inject it in the area, and it reduced inflammation. What did it do?
So there are two different there's two different main categories of PRP. One is you just take the platelets whole and you inject them into whatever structure you're trying to heal. Okay. The other ones are platelet lysates, where they use an enzymatic reaction to extract all the growth factors. So it actually skips a step. You don't have to break down the platelets. It's already done. All the growth factors are just freely in the solution. So you put that into whatever structure you're trying to heal or reduce pain in, and it recruits your body's own cellular repair mechanisms. These are very powerful signaling molecules. And there's evidence to support that. They're all pretty small trials, like maybe 50 patients or less. But a lot of people are studying it or have studied it, and there really are very few adverse outcomes from it. The problem with it is that, again, I mentioned, regenerative or stem cell therapy light, that those platelets and those growth factors in someone, our age, aren't very potent. There aren't very many growth factors left compared to, say, an infant or a teenager, right? These things really start to drop off at about age 30. And most of the people we're treating are not 20 years old, okay? Barring some athletes in accepted cases. But most of us are in our 40s, 50s, 60s, or 70s and active in activities. And using these therapies just isn't going to give you the outcome that you want, because unfortunately, we're getting older, and so are our growth factors. So that kind of brings me to the next segment. So we went from that to harvesting stem cells, autologous and allogeneic stem cells.
What does that mean?
So autologous means I take it from, if I'm going to treat myself, I take it from my body. Either fat or bone marrow is a typical source for those stem cells. And then we, through enzymatic reactions and centrifuge, we actually concentrate the stem cells, and then we put them into, and not, when I say stem cells, that also is including all the growth factors, okay? And so we put them back into the body, whatever injured structure we're trying to repair. That's a surgical procedure, right? Because that's a two-step surgical procedure. Because first I have to collect the stem cells. So I either do that through liposuction, which a lot of the women like that. I'll be honest. It wasn't hard to get people to sign up for that. The bone marrow is less attractive because most people are complaining of pain from the bone marrow donor site.
But is it the most effective? Because I know people are going to Cayman. They're saying these. But look, I'm more confused about this than ever, because whoever I talk to, I get a different story. But isn't the bone marrow going to be the strongest stem cells, or that's just not true?
We don't know. If you look at these studies, there are a lot of studies, and not a lot, but there are quite a few studies, and all of them are around. Some are 40 patients, some are 24, some have a 3-month follow-up. Rarely do you have one with greater than 6-month follow-up for bone marrow and mesenchymal. We'll just call it mesenchymal stem cells, which can come from fat or from bone marrow. Then you have hematopoietic stem cells that come from the blood. Okay. But which are much less studied. The concentrates in the mesenchymal extractions are much higher. And those, like I said, they've been studied, just not with these large populations.
Is it legal, by the way? Are bone marrow stem cells in orthopedic or pain management, is that legal here in the U.S. as of today's date here in 2020, ending 2020?
Yeah, it's legal, but you have to understand what you're dealing with. You're dealing with donated tissue in many of the cases, or your own tissue. And it has been the FDA's position that this falls under tissue, okay, and not a drug. So the FDA, until about 2018, when they really stepped in and said, look, guys, this is the Wild West, and there are people being injured, and we're going to start looking at all this, and you're going to have safety data and outcome data really by this year. Now, I don't know with COVID, where we are with that. I think we have some delays on it, but it was really November of this year they gave a deadline. And if you're making false claims without evidence to back it up, you're going to be in trouble with the FDA. So it's legal, but it's regulated under a federal title.
So you can go to a doctor, get it done, but they just can't promise you it's going to work.
No, you can make no promises that you're going to regrow structures, that you're going to heal cancer or any of these some of these things these claims are crazy, what physicians claim. In fact, I'm sure you're familiar with the intraocular, inside the eye injections that several clinics were doing. I won't mention their names, but some people are going to prison over that. They blinded 6 or 8 patients, had terrible outcomes. So you have to be careful with what the physician is telling you, and that's another important part to kind of digress for a minute. Many of these clinics are owned by non-physicians, say a chiropractor, which is a chiropractic physician, but they're not a medical doctor, and they will employ nurse practitioners. And so you want to make sure that who's doing these procedures on you is board certified and well trained. And as you mentioned earlier, didn't learn how to inject in a weekend course, because this takes years. My colleagues that have been involved in this since the beginning, 16, 18 years ago, they know what they're doing. They're the ones that publish these studies, and they'll be the first to tell you that this isn't without risk. So we can mitigate the risk and make it almost negligible if you know what you're doing and you're an experienced physician, one, accessing the structure that you were talking about treating, and two, knowing when to treat and how to treat with these regenerative products.
And so, for example, I mean, look, you're in the pain game, every single day. So if what you do doesn't work, they're going to complain to you. Doc, I'm still in pain, right? So you have the luxury of lots of patients that you've tried this on. But let me ask you this. So when you go to one of these weekend courses, whatever, you're learning stem cells, because I know that those are available and out there. I know one of the guys that heads up a big organization that's going around the country. They're not making claims, but they're saying, hey, the stem cells may or may not work. But they're blindly injecting it, meaning you have a shoulder hurt, it kind of goes in a certain area. Whereas with you, are you looking under fluoroscopy? Are you guiding this? That means your needle is going in more precise than theirs?
Correct. Yeah.
Because you know a thing or two about where the pain's coming from. Is that right?
Right. And that's an important part of it. I mean, the physical and imaging workup on these patients, you've got to narrow down what the pain generator is. If you go, for instance, and we can talk, there's a new product we need to talk about, or a new therapy in the disc, and we kind of touched on it before, but if you're going to go into a disc, there's a lot of structures around that disc that you don't want to hit. Nerve roots, spinal cord, depending on where you are.
Does that happen a lot, frequently?
And untrained hand. Yeah, I'm sure, I've seen nerve root injuries from lesser qualified physicians that may be using fluoroscopy but don't know how to use it effectively. Before I started doing these therapies, I was already doing minimally invasive spine surgery, endoscopic spine surgery. And the top guys in the field, all of us were trained to do that back in the day. And we have decades of experience accessing these structures. Prior, to regenerative therapy, we were doing the old-fashioned, surgical procedures. But I think it's very, very important that before you let somebody, access a disc, which there's major risk with that if you don't know what you're doing, you make sure they know what they're doing. They're well trained. They didn't just go to a weekend course. They've been doing intradiscal procedures for a long time.
And it doesn't cost more money to go to a guy like you. I mean, Medicare, Medicaid. I mean, I know a lot of this is cash pay. We should talk about that right now. But it doesn't cost more to go to somebody that's done just about more than anyone there in Arizona, or has well trained in interventional pain management. Doesn't cost more, right? It's about the same wherever you go.
Or less, actually. Many of these so-called stem cell clinics that are run by non-physicians, non-medical doctors, they actually charge sometimes 2 or 3 times the amount that the qualified physicians charge.
Now, by the way, you made, I was reading your bio, but you made your career preaching against opioids in 2003, 2004 for people that are getting hooked. And, look, we know if you're in chronic pain and you're not just a drug addict, that for some of these people, it's life-changing, takes them out of pain. So even though you were speaking out against it, you were able to use alternative therapies, interventional techniques to get people out of pain without opioids?
Correct. Yes. I mean, opioids have a small place. Clearly we all have patients that are 80 years old and have heart disease and other comorbidities that just aren't a candidate for any type of procedure. I mean, they can't come off their blood thinners. So what else are you going to do with a patient like that? And I think using what I call responsible opioid therapy is indicated in those patients, which means low dose and doing it in a controlled, safe fashion without mixing it with benzodiazepines like Valium and, medications like that. I think there's a small population that do okay with it. They never do well. They never get, significant restoration of function. They don't go back to work. But in that population, it's okay. And we all have those patients. But the vast majority of people we're talking about that have been maintained on opioid therapy for the last 30 years, that's not the case. And many of these patients, I think I mentioned when we talked earlier, you're damning these patients to a terrible life. They don't go back to work. It destroys, family relationships. I mean, they have no quality of life.
So there's things you could do to get them off the opioids and into a more natural thing. And that's what interventional pain management physicians do. Is that correct? Look, I interviewed the president of the society, the founder of the society, and since then I'm asking around. Nobody knows what an interventional pain management person is. My neighbor has had 2 fusions. My good buddy from high school, fusion. Never heard of interventional pain management. Never even thought to ask for pain management, and I let them watch some of my shows, and they're almost frustrated, going, "Why didn't I ever see one?" I guess you have to ask.
You do.
Or you're the guy of last resort when they're so damaged. Let's give it to the interventional guy and see what he can do. But it's too late at this point. Is there a little bit of that going on?
There's a lot of that going on. It's region specific. I mean, the surgeons that I work with here are fantastic. There's some that I don't work with because they're not. And in many cases, like, one of the big hot spots is Reno. I think they have more spine surgeons per capita than any place else in the country. And if you get sent to that surgeon,
is it because it's like loosey-goosey on the rules?
That's my understanding from physician friends of mine who are interventional pain physicians there, and unfortunately, I mean, they're doing a great job in changing the opinions of family physicians who are the primary referring physicians to the surgeons, and getting them into interventional pain physicians before they go down the road of surgery. I mean, there's some patients, you have a car accident, you have instability, neurological deficits. Guess what? You have to have surgery. I mean, there's no other way around it. But that's maybe 5% of patients, maybe 10 at the tops, have instability in their spine and need a fusion. The other 90%, they would do very well in many cases not having surgery, except as a last resort. And we have, as we talked about, regenerative medicine aside, you can do injections. Sometimes they're very, very effective, and while they only give temporary relief, a lot of times, if you can maintain somebody their function by reducing pain, 6 or 8 months later, their body heals itself.
Okay.
And so, but without surgery, which is the best case scenario. Or many cases, we intercede with. Remember, we talked about spinal cord stimulation, a very underutilized therapy, which is very effective at controlling pain. So there are a whole lot of things that we can do outside of medications to effectively control pain and prevent surgery.
Is it like anything else? I mean, obviously, a guy like you wants to get people early, but the challenge is they come in when they have a lot of disease, lots of breakdown of the tissues. So if you get a guy that's a tennis player or a golfer and it's just starting to come on, is that ideal in your opinion? If I could get him in on some of these regenerative therapies, we could probably stop it, save it, and maybe even make it stronger.
I think in the next 10 years, you're going to see a transformation in my field, and even in surgery, and spine surgery, and orthopedic surgery, where that is the case. Because, what have we had before? Before we had regenerative therapy, all we could do was kind of chase the ball after the play was over. Now, as you mentioned, we can intercede much earlier with regenerative products. So say you have a partially torn rotator cuff. What did we do for that before? Take ibuprofen, go to physical therapy, and hope it heals. And many times, when you're in your 40s, it's just not going to. You're kind of past the point of being able to heal your body many times. So, so then what you do is you wait. You wait until the pain gets really bad. You wait until those tendons completely avulse, tear in half, and then guess what happens?
What?
You either get in many cases, if you don't, if you have a torn tendon, they can repair it, but it fails many times. So you just kind of have to live with it, and then when it gets bad enough and you get old enough, they'll do a reverse total shoulder on you. They'll replace the joint. Okay, so that's kind of barbaric as I see it. I mean, that's what we had, but now we have a real opportunity to intercede very early, maybe when you're 40, and stop the progression of the disease, heal the structure potentially. Not in every case, can't promise that, but we're seeing magnificent results with these therapies.
And does the body know how to heal? Like, for example, when you put stem cells or regenerative therapy into that area, does the body know, like a starfish grows its arm back, does the body figure out how to like make that rotator cuff that was torn? It brings it back together in the functional way that it should be?
Sometimes.
Are you finding that?
You mean in the absence of treatment?
No, I'm saying with treatment. I mean, what I'm saying is, are you seeing that when you inject these therapeutics, these regenerative cocktails with stem cells, are you seeing that this rotator cuff grows back to where it used to be, physiologically, the way it was?
In many cases, we have MRI evidence of regeneration of tendons or healing of tendons, regeneration of cartilage in the knees and hips, and other structures we treat with these products. There's really two schools of thought. They're the hardcore stem cell physicians who believe that those cells that we're putting in there actually are forming new structures, okay? And these are progenitor cells, like mesenchymal cells that we talked about earlier, or bone marrow stem cells, that can morph into structures that you put them next to. Say, for instance, I want to heal the tendon. I put these progenitor cells, these stem cells, that can turn into a lot of different structures in the structure. In the 900-foot overview, they kind of form new tendon fibers, okay, or new cartilage, whatever the structures you're trying to regenerate. It's far more complex than that, because what we're seeing in many cases, and I mentioned earlier, I've used extensively acellular preparations that just have a ton of growth factors and cytokines, signaling molecules in them, and other types of biomolecules.
Signaling molecules are these things that you're injecting that call in the body's immune system. Okay.
Well, yes, the immune system and your own repair mechanisms, which guess what, are stem cells. It's just unfortunately when you get old, you don't have many of those floating around. So you've got to maybe send out a red flag. Hey, I'm over here, I'm injured. And that's what these growth factors do in a nutshell.
Okay.
And then we think that's how the body's healing itself. It forces your body to turn on its cellular repair mechanisms.
Now, in plastic surgery and dermatology, they do microneedling. They're doing holes in your skin, and then they're doing a little PRP. But that injury forces the body to kind of send the healing growth factors there for elastin, collagen to rebuild this, and some stem cells go into the area. Is that kind of what this is doing, but without the injury of?
And it's a double-edged sword when you're talking about, and that goes back to prolotherapy. You're causing a massive inflammatory reaction, right? So you have to be careful. You can get scar tissue. It may go the other way on you. You may cause damage. So that's a risk. What we're doing is using very minimal mechanical trauma, very minimal, with very small needles, typically, to put these products in, which are actually anti-inflammatory. So reduces the inflammation, which impedes healing. The inflammatory cascade is complex, but typically that's your body sending out, a red alert that I'm injured. But there's a downside to it, and the downside is those inflammatory molecules also cause damage. Okay. So when we use these very potent growth factor or regenerative products, they actually are anti-inflammatory, much more so than steroids, anecdotally. That's what we're seeing. And so we think that we're not causing this additional inflammatory cascade. We're actually shutting it down and preventing scar tissue from forming, which can impede healing of a structure. And many structures, when you're older, that's like when we say a disc heals itself, it doesn't heal itself. It forms a scar, which is weaker than the outer, the annulus fibrosus, which is what your normal native state of nature there is with the disc. That's the outer covering, the thick fibrous coating of the disc.
Preparing a little bit for this interview, I was talking to one of my plastic surgery buddies, and he knows a little bit about it. He's been to a couple of weekend courses, and he says, my wife had horrible neck pain and even headaches associated with it and shoulder pain. He injected her. I don't know where he injected her, but he injected her neck. He goes, and she's been fine for 1 year. So there are these stories, and he did it blindly, without the fluoroscopy that you're doing it. So there's stories of people getting lucky. You just inject the area, and these growth factors, stem cells kind of do the work. Is that
I hope
right?
it was. But I hope that was intramuscular, not in the actual spinal canal without fluoroscopy.
Yeah, probably not. Now look, here's the other thing. You got, somebody says, younger stem cells are better than older stem cells. So for example, they're saying Randy Cord, like my hair transplant buddy, he's Dr. DeYarman has been doing it for 40 years. Right. And he's saying that these cord blood stem cells are the best for regrowing hair. And then you have some people that say, yeah, but then you've got these exosomes, and then they're talking about, the fat, the stem cells that come from fat are really the best. And then sometimes they're saying, it's just the marrow from yourself, so are different stems. So if you could elaborate on just kind of the things that I just said.
Well, some of those are
in a short way. Go ahead.
Yeah, so let's talk about the exosomes and the cord blood. Those are very controversial, and the FDA is taking a hard look at them because of some adverse outcomes associated with them.
So the baby cord blood is controversial, but it's legal. What's controversial about it?
Well, you can have maternal blood contamination of it, and you could get a transfusion-related reaction. There are cytokine storms that can happen, which is a massive inflammatory reaction in the body when you put some of these products, when you put them in a knee or in the bloodstream accidentally. There's some potential adverse outcomes associated with them. And as I mentioned earlier, we have scant scientific data to back up using those products. There isn't any. It's very little. Platelet PRP therapy has far more data and safety and efficacy than what you just mentioned, than the exosomes or the cord blood. We have significantly more data on using mesenchymal and bone marrow aspirates than we do using exosomes or cord blood.
So can we talk about I called it earlier a cocktail. You never called it a cocktail, but this regenerative product. Let's just say that it's a shoulder, like a torn something, right? So where are you getting these stem cells then if it's not from the person's body?
Well,
is there a bank? Are you freezing them? Are they like sub-zero storage? What is it?
All right, so what you're talking about is using allogeneic, meaning from some other source besides the patient, okay? So there are various supplies for that. There are tissue banks, as you mentioned, and many of those tissue banks have amniotic fluid, okay? That's from donated C-sections. Healthy C-section donors or healthy C-section patients donate their amniotic fluid, and many of these tissue banks bank it, and then they freeze it in a cryopreservative. So that's the simplest form of a regenerative product that's from another source, okay?
You have some of that? Do you do some of that?
Earlier on I did. I don't use those products anymore. As far as the amniotic, just the pure amniotic formulations. So what I use now with the amniotic solutions are acellular preparations, and those are terminally irradiated, meaning, you've got an amniotic source with a little vial of amniotic fluid, and they terminally irradiate it, which removes any living cellular material. Also would remove any infectious material, okay, potentially. Even those are screened and they do cultures and so forth, there is still a very small possibility that those could be contaminated with an infectious, virus or
But the
bacteria.
stem cells live through that radiation?
There's no stem cells in those, right?
Oh, it's just growth? What is it?
It's just growth factors.
Just growth factors, okay.
Yeah. Nanoparticles, biomolecules, like the exosomes, those are in there. We know they're in there, and they survive the terminal radiation. But mostly it's all these transcription factors and growth factors that turn on your own body's cellular repair mechanism that's in these products. Some of them.
Let me cut in for just a moment because there is controversy around this subject. So what you just said, they're not really stem cells or growth factors. Right. But many practitioners doing it are telling the patients these are stem cells.
And that's a slippery.
Is that right? Is that true?
Oh, absolutely.
And that's where the problem is. Okay.
These stem cell clinics, and we just, you can't make a claim if you don't have the data to back it up. And so I can't tell you that some of those so-called stem cell therapies, that some of the stem cells don't survive and don't get into the injury structure and don't incorporate with the native, say tendon or cartilage. I can't tell you it doesn't, but we don't have any evidence to support that it does, okay? But what we do know is that if I take an acellular, meaning devoid of any cells, any living cells, preparation of a growth factor formula and put that in a structure, I can in many cases see healing, I can see reduction in pain, I can see MRI evidence of regeneration of tissue in many cases. That we know. So that's what I tell patients. I don't tell them that I'm going to be able to transplant stem cells from their fat or from an outside source, and that those stem cells are actually going to do anything because we don't know.
So with what you're doing, it's kind of like it's really like a biohack. It's a way to kind of take their growth factors, their immune system, their healing properties, the defensins, whatever, and put that on steroids, as I like to say. That means you're kind of beefing up your own system to heal itself better, faster, right?
Exactly. Which is why, in patients 60 and under, that's the target population. Now, I've had a lot of success in older patients, but you're not going to see the same types of restoration of disc height and other things that we're seeing in the younger patients, typically in the older patients, because their cellular repair mechanisms are damaged. They're old, unfortunately. So that, I mentioned there was another product now we have that has probably more evidence than anything else that we're using. I'm very excited about, and it's for lumbar disc pathology. And it actually, they've done 12-month studies on 224 patients. And the
with low back pain.
With low back pain, yeah. It's unbelievable. So this product's kind of a mix of several different things. So It is donated from cadavers, basically, people who donate tissue upon their death. Nucleus pulposus, which is the center of the disc, okay, which has a lot of proteins and other cells in it. And as you get older, those cells start to dissipate, right? So you can't repair the disc as you get older. So maybe after age 40, your chance of repairing the disc is pretty low when you suffer an injury. And then they also are harvesting the adjacent vertebral bone marrow, right, which does have stem cells in it, as well as all these other growth factors we talked about and anti-inflammatory cytokines. And this is in a small preparation, and you actually just inject it into the disc. And like I said, they've done, probably to my knowledge, that's the biggest study, 224 patients studied over 12 months. Excellent outcomes.
So look, I've had, look, we should mention, I mean, you live, eat, and breathe this. Your wife's a chiropractor. Is that correct? And so you know a little bit,
She's a mother. She's a mother right now, and she's on temporary leave from her professional career. But yes, she is.
So are most spine problems, like when people say bad back, bad neck, it's the discs are so slowly having problems. They're kind of breaking down. They're shrinking. And some people need fusions. So if you can get, I guess in the future of medicine, if you could get to these people earlier, you could keep this big shock absorber, these discs nice and fluffy and puffed up like you were as a kid. Is that kind of what you're trying to do?
That's the idea behind it. I mean, if you look at, as discs start to degenerate, there are changes you can see on MRI, and we call it disc desiccation. So the water content of the disc starts to dissipate. And so, and the height will start to drop as a result of it. And then the disc becomes brittle and is, subject to injury.
So you inject it right into the disc, into that disc area. Is that like a cartilage? What's it made out of? What are discs made out of? Is there a way?
Well, yeah. So there are cartilaginous structures. The outer coverings are this tough annulus.
But do they feel spongy or kind of like rubbery when you
feel
them?
They're more rubbery. Yeah, okay. They're shock.
So you inject it right into there, and have you seen on MRI or whatever imaging you're using that they're getting taller or bigger or fatter?
They have evidence in some of the patients that had excellent outcomes, which was substantial, that there is restoration of height. More importantly, there's restoration of water content in the disc. And then if you look at, we have indices like Oswestry and VAS scores, which deal with function. Okay, so their ability to golf and do all these other activities goes way up, and the pain goes way down. And that's what they were following in these 224 patients over 12 months. And now we've got a much bigger study going on, a registry, where we're following outcomes in thousands of patients over years.
Have you given family members regenerative therapies?
I have.
Okay. Neck, back, shoulder, knee, what?
Shoulder, wrist, spine, yes.
Great results?
In some cases, yes. Like I said, the failures are typically in the older patients that are over 80 that have profound pathology and they need a joint replacement. And sometimes you just can't avoid it. But to your point earlier, I think the earlier we get involved or intercede with these regenerative therapies, and say a 60-year-old or a 40-year-old, the less likely we are in 20 or 30 years to be facing, the same types of barbaric, as I call it. I know my orthopedic surgery buddies hate that term, but, going in and cutting bone out and sticking, plastic and titanium in there, that's kind of barbaric. When you can just do a injection and prevent that from happening.
I mean, the only reason why people are getting surgeries in the first place is to get out of pain, usually, right? That's it. So if you could get out of pain with maybe like you do these spinal cord simulators, implantable devices that confuse the signal to the brain so you don't feel the pain. So you're going to do everything you possibly can to do without surgery or drugs. Is that right?
Yeah, exactly. If it's not, like I said, if you have instability in the spine, sometimes you just can't get around having a fusion. But in many, many cases, the vast majority of the cases, that's not the case. You can do other therapies and prevent, a really potentially disabling surgery.
When we peek into the future, do you think that the so-called high rollers, the ones that are taking bioidentical hormones and progesterone and testosterone and thyroid and estrogen and, that crowd, some people are taking growth hormone. Do you think that there will be people in their 40s that go routinely and just get their discs injected just for like an insurance policy against the future? Do you think that'll ever happen? Is it happening now?
It's happening now. I have several patients who are physicians that are in the know that are already having these procedures done.
And they have no pain. They're just doing it.
Yes.
Wow.
or minimal pain. Yeah. I mean,
The
they had minimal symptoms, which prompted them to get an MRI and see the changes in their disc. And they're like, look, I'm a skier, or, they play, they ride mountain bikes or whatever it is they're into. And they want to prevent, when they're 60 years old or 65, 70, having back surgery. And they know what's coming for them, because one of these guys is a very prominent neuroradiologist. And so he reads all these MRIs and knows what happens to these patients. And he's, in his early 50s, and I'm going to treat him in the next couple of weeks because he doesn't want to go down that path. And in fact, one of my colleagues is really Tim Davis, Dr. Davis out in California. He was one of the big guys behind this study. He'll be doing my spine here probably in the next year, because I don't want to.
And you're feeling good right now. You're doing it for prevention.
Well, yeah, I mean, I have minimal symptoms. I fractured my spine when I was 20 jumping out of helicopters. So now that I'm hitting 50, it's starting to come back for me. But I know, because I treat these patients all the time, I know what the future holds for me, and I don't want to have a fusion. So I'm going to prophylactically have this procedure done the next year, so that I don't face that myself.
That's where this is kind of going. One of the biggest podcasts in the world, Joe Rogan, I've been told that he's involved in the fighting, the MMA fighters, the guys that are fighting with very little gloves and just killing each other out there. But he said, and I'm hearing this from a lot of different people, that these fighters, after this brutal match, they fly to Cayman and they get infusions with stem cells. They do all this stem cell stuff, injections, and they're spending like, who knows how many thousands. Have you heard things like that? And is that kind of what we're talking about? I mean, for those extreme athletes, why not?
Well, so-called stem cell infusions are really, really dangerous. Okay. You can have a stroke, among other things, and unproven. And that's not something I would ever recommend. And the FDA is very clear about that as well, for good reason. I think having, and I will preface this with, there's a famous hockey player, Gordie Howe. I'm sure you're familiar with Gordie Howe. He had I think it was 2012, he had an unbelievably catastrophic stroke, and he's Canadian, and his son is actually a very prominent Canadian physician, and he was flown down to Mexico, where he underwent really extreme, very dangerous regenerative therapy with stem cell therapy, and he was able to come out of a coma, and he actually gave a speech at the NHL Banquet Awards, I think like 2 years later. So there are some one-off, magnificent outcome stories, but there are a lot of bad adverse outcomes that can occur.
When you say bad outcome, okay, so you're putting these regenerative properties, these growth factors in your head or your arm or whatever. Mm-hmm. So is the thought like, well, they're stem cells. I mean, how's it going to hurt to put growth factors in your body? So what could it grow? Cancers? Could it? I mean, what is it? Is it triggering the immune response that maybe you could have overdoing the immune system? Like, what are the dangers here?
All of those things, as I mentioned, one of the most immediate results from an IV infusion would be a stroke or a heart attack.
But what do you guys have an idea of what the mechanism, what's causing that? Is it raising stress hormones? I mean, what is it doing?
Yeah, it could be causing some sort of inflammatory reaction. It could be a transfusion-related reaction where there are, non or immunogenic proteins in the formulation in your body. It's like a transfusion reaction. When you transfuse the wrong blood group into a patient, you can have an immediate, life-threatening and sometimes life-ending reaction when it's all hands on board. So that's one of the mechanisms. And you mentioned cancer, right? So that's kind of a very strong contraindication to using these products if you have a history of cancer, because while we don't have any evidence that it is going to cause a senescent or non-diagnosed cancer to grow, the science, knowing what we know about these growth factors, it could if you had prostate cancer, for instance, history of prostate cancer, breast cancer, it could cause the disease to come back. It could cause it to go from stage 1 to 4. We don't know. So those are patients we try to avoid using regenerative therapies in. It's
a bit risky.
And so there's another thing. Go ahead. I was going to say there's also the bioflare we talk about, And when we're using allogeneic products, meaning from an outside source, cadaver or C-section donor, particularly with cord blood or these exosome preparations, you can get what's called a bioflare, where you get a massive inflammatory reaction that can be systemic, meaning body-wide. And it can mimic an infection in the disc. It can have all sorts of terrible symptoms to it. And that's a well-described phenomenon. So you have to be careful with that as well.
Yeah, this is, look, when you knew you were going to do this interview and I said, look, I'm going to kind of press you. And I know you're a real doctor. If I'm talking to a salesman, they're promising me the moon. Like I was talking to a stem cell manufacturer or distributor that sells it to the doctors, right? And this guy's just rambling on and making every promise in the book. And a lot of people don't know that most of the medical doctors are learning from these reps, stem cells.
Yes.
Is that true?
Yes. I don't know that most of them are. I know a lot of them are, particularly in these so-called stem cell clinics that promote this. They do these live lecture series, and they rent out hotel rooms, and most of those are owned by chiropractors. My wife, having been involved in the field for many years, was the first person to really tell me about the down and dirty of what some of her colleagues do. And they hire physicians or nurse practitioners, and the chiropractor will go around because they're great salesmen, many of them. And my wife's the first to tell you about it. And they will make these outrageous promises, and there's no repercussion against these guys. They're not the medical doctor performing the procedure, and except that the FDA comes after you. I mean, then there's
so they're a bit opportunistic. It's like, hey, stem cells are hot right now. Let's get in the game.
Exactly. It's cash, right? I mean, this is and you're playing off people's patients' weaknesses, and they want to get better. And many of these people will do anything or try anything, even unproven therapies, to get better. And I get it.
Let's talk about the cost. Like a typical person, they're in their 40s, they're having some knee problems. Mm-hmm. You've done whatever diagnostics you need to do. Could that be anywhere from like $2,500 to $10,000? I mean, what does something like that cost?
I would say
like roundabout.
If you're using an amniotic source product, somewhere around $2,500 to $3,000, depending on the volume that you need. I'd say that's and what type of imaging you're using, or whether you're using a scope to go into the knee. That would be about right for a knee, somewhere around there.
And so many of these people for $2,500 avoided knee surgery, and they're back on the court, back on the whatever.
Right, absolutely. And you don't have the trauma of the surgery. Okay. And then, if you have private insurance, what's your deductible for that? So just having a knee scope, in many cases, it's several $1,000s. And just by having a simple, procedure, an office procedure, if done right, you can avoid that potentially. And
at the high end, how much are some of these procedures?
Well, it's really volume dependent and how many structures you're targeting. For instance, going into a disc, I mean, that's kind of takes the most training, the most experience, and has probably the most risk of the structures that we treat, outside of doing, really off the reservation treatments, like we said, IV infusion, for instance. But that can run anywhere from $3,000 to maybe $6,000, $7,000, $9,000, depending on how many. And
you're only going to move forward. I mean, you're only going to take $3,000 or $6,000 of somebody's money if, in your mind, that you think this is a good candidate. Is that correct?
They have to meet
with a high predictability that it's probably going to make some sort of an impact.
Absolutely, yeah. I mean, for that particular product we're talking about, the intradiscal product that's fairly new in the last couple of years, there are very strict criteria as to how far the disc can have degenerated, the age groups that we'll treat, because we want to have successes here. We want this to be a viable treatment option. And we're hoping that insurance will see what we're doing and go, you know what? This is saving us millions of dollars potentially in failed back surgeries. So we're going to start covering it. And I think that's probably, hopefully, just a couple of years away before this becomes mainstream treatment, because we have the data to support it.
Now, these centers, right, that are blindly, I'm calling it blindly, but where they're going in not under fluoroscopy, and they're just kind of shooting the general area, right? And they get, in some cases, some miracle results, good results. But if you can do it guided and go to an interventional pain doctor, since you're paying about the same price, and the other thing is, this is my hunch just from listening to you. I don't know if this is true, but it sounds like that most of these stem cell clinics or so-called stem cell clinics that are treating, low back pain, neck pain, that they're not going to the disc because that's too tricky for them. They're just going in the general area. So where you're actually going you're taking those growth factors and you're going into the disc, which it puffs it up, adds more fluid, all of those things, which is mostly the pain generator is somewhere in and around the disc with back pain, low back. Is that right?
Well,
so they're kind of missing the mark. I mean, they're not really hitting the area, just going around the area.
You have to look at every patient individually, right? So I have a very complex analysis that I perform on the patient before I decide what I'm going to treat. Not every patient is a candidate for an intradiscal procedure. For instance, if they're 80 and they have almost no disc left, you're not going to do that patient any good. In fact, you may harm them by going into the disc. So you may treat the peridiscal structures with an amniotic product, growth factor product. You may treat the facet joints with a growth factor product. You may treat some of the ligaments, the interspinal ligaments, with a growth factor product. So you have to approach every patient differently. There's no algorithm. This takes years of experience to really, one, be able to diagnose what the most likely pain generator is, and then two, to decide what treatment you're going to offer that patient, if any at all. And sometimes, the patient is not a candidate for any regenerative products. They're too far gone.
I mean, so there are people that are probably coming in and say, look, doc, I got plenty of money, whatever it takes. Here's $10,000, whatever. I mean, so sometimes you may have to slow them down and say, in your particular case, this may not be the most effective treatment. And have you ever said that before?
I have. I have one patient that stands out among all others. He was one of my earlier massive successes. And this guy was a Marine, recon sniper, special forces, Vietnam and beyond, 30 years. And he's now makes cowboy movies. He's one of the stuntmen, that jumps off.
Okay.
And so forth. Yeah. So he has wrecked his cervical, thoracic, and lumbar spines. And I looked at the pathology. He has pretty profound stenosis and among other things. Nothing that's unstable, but he has almost every level in his spine is catastrophically injured from all of his shenanigans, fun stuff that he did his whole life. And I just had and he has a lot of money, by the way. And I said, look, you're 75 years old, and I can't possibly treat all these levels. And first of all, secondly, I don't think this is going to help you. I think you're too far gone. He said, I'm not having surgery. I refuse. Okay. He said, look, would you at least consider treating one area that's really painful, his low back? I said, okay, we'll just do the one area, it was 3 levels actually in his lumbar spine. I'm not going in your disc because you don't have much left. And I will treat, the peridiscal structures. I'll treat around the nerve roots where there's some scarring and inflammation.
And you're doing this under imaging. Is that correct? So when you're injecting, because I've seen this done at another pain management guy, but so while you're injecting, you're actually looking at the monitor.
Yeah, in many cases, I'm using 2 different C-arms, 2 different X-rays machines. One is lateral, and one is what we call AP. It's vertically oriented, so I can see in real time in multiple dimensions where I'm going. Particularly when you're going in the disc, that's very important.
I interrupted. What happened to that guy? Yeah.
So I was a naysayer, right? I said, as a physician, you shouldn't do this. You should be optimistic. But I was trying to talk this guy into having surgery, which I firmly believe was probably his only way to get better. And sure enough, he came back at 6 weeks, and his back pain was nearly gone. And something we haven't talked about is these products, these therapies usually take about 6 months before they plateau. But he was an early responder. And I've seen people, not often, but I've seen people have a knee injection and get off the table and not have any pain. It can be very quick. So not all the time, though. I mean, that's not the typical patient. But anyway, so then he says, you know what, doc? Let's go to my thoracic spine. And again, I said, well, we got lucky here, right? Your thoracic spine, there's 12 levels of chaos up here. Where is your primary pain generator? Where's your primary area of pain? And we narrowed it down to about 5 levels. And he's like, look, again, money is no object. I just don't want to have surgery. And I'm so happy with my lower back. I want to treat my thoracic spine. Again, I'm not making any promises here. And I would say your chances of getting better are maybe 20%. I'll take it, he said. Okay, so we treated that area. And guess what happened? And when I treated that, I said, after this, we're done because this isn't going to work. And we're not going to even mess with your cervical spine, which is terrible. Multiple levels of stenosis. And there's no way this is going to work. Comes back, thoracic spine is great. And it continues to improve. Both the lumbar and thoracic spine improved over 6 months. Now he's begging me to do his cervical spine. What can I say? I mean, I didn't think it'd work in the thoracic and lumbar spines. Okay, fine. I'm not causing any damage. I'm not going to cause any damage to him. All I can do is help him.
And how old is this guy?
75.
Okay.
And
So now you're going to do his neck. Have you done the neck yet?
Oh, I did it like 3 years ago. This was 3 or 4 years ago.
Okay.
I think 4 years ago, I finished treating him. And this guy has sent me so many of his friends. He's completely asymptomatic. He's still doing his boy action films. And yeah, he's in fantastic shape. He's pushing 80 now. So, we have, I think.
So you're surprised sometimes then at the results?
Yes, I am. And this guy didn't meet the criteria where it should work, right? But if you're not going to harm someone, and really money is no object, I mean, I would be the same way, right? I don't want to have surgery. And if I can afford it, I'm going to do whatever I can to avoid having surgery. Having had failed knee surgery before, I'm the big proponent. I had that done before I knew about regenerative medicine. I was, younger in my medical training. I now, if I tear another ACL skiing, which I still ski, I'm getting regenerative therapy first. And I kind of do it prophylactically anyway because I've had such damage to my knee from skiing. So I think so far I've staved off 2 more operations as a result of it.
Is that right? Well, now, when you knew you were going to, and we're nearing the end of this podcast, but when you knew you were going to be part of this, what did you want to make sure that you got across? Like, what did you say, man, I want to make sure that they know this? Is it more of a warning or is it more of the benefit? I
think it's both, Andy. It's both. I mean, just be informed. And, Google actually is not a great place to become informed necessarily. There's a lot of Google. Oh, yeah. I call it the Google. But the Google is not a doctor.
Dr. Google. I call it Dr. Google. There's a new doctor in town because that's where people get all their advice.
I think you have to be an educated, consumer. I mean, that's what we're talking about here. You're talking about paying money to have something done. So, I mean, these are patients, but they're also consumers. So, and it's not like you're buying a product that may not work. You could buy a product or have a procedure done that could cause catastrophic damage. So you have to be very careful and educated about what you're doing. So I would start with the societies like the American Society of Pain and Neuroscience, which I was one of the first 75 physicians in, at Aspen, as we've talked about that before. Any of the physicians in Aspen are well vetted. You can't just join it. You have to be asked, and we have to be nominated by 5 of us, all right? So all of these physicians who are neurosurgeons, interventional pain physicians, radiologists, physiatrists, et cetera, they're all well vetted. We don't let quacks in our society. That's what differentiates this society from the other societies, like the American Society of Interventional Pain Physicians, which is a great society, ASA. But anybody can join those if they have the education behind them, in degrees and fellowship training. You can join these societies. So start with a reputable society. Look at the physicians in that. Look at their publications. And I mean, I'm happy to give information to people if they're in a different part of the country. I can usually steer you to the right physician that's reputable, that won't cause damage, that knows what they're doing. And there's a big network of us that are involved in these studies and this therapy. So start there. If you go to a hotel, Marriott symposium, probably that's not where you want to get your health care. Okay, those are snake oil salesmen. I mean, for lack of a better term, they're snake oil salesmen. Be very careful. And there's some big names.
That must frustrate you, after your 20 years of education on this.
Yeah.
And it just kind of must bug you. Yeah, because it could give this whole regenerative medicine a bad name. Because if they don't get results, they're going to tell their friends, I tried it, didn't work. They think they tried it, but they didn't.
Mm-hmm. They didn't. And that's the unfortunate thing. And more importantly, now, because of some of these unscrupulous characters, we have the FDA breathing down, and it's entirely possible if we have more bad outcomes from people injecting in eyes and doing IV infusions, that the FDA could issue a cease and desist against everybody. And now we've lost this magnificent therapy because we haven't been able to regulate ourselves.
Because they're doing ears, they're doing everything. People that are hard of hearing, they're injecting everything.
Be careful. I mean, you and I have talked about hair restoration, something that I do, and it works. It's phenomenal. And you know what the risk to that is? Money, right? If you might lose a little money if it doesn't grow. But the risk of having a complication from that is so negligible, it's not even worth talking about, all right? Versus having an IV infusion or having a product put in your ear or having a product put in your spinal fluid. Those have real risk, and it's unproven therapy. So be very careful. If a physician says, let's do an IV infusion to boost your immune system or to help your lung function, you better be very, very careful if somebody recommends that. And find out who this person is. Is this a doctor that's going to do the procedure, or is it a nurse practitioner? Because in many of these fly-by-night operations, you have a nurse practitioner who has 1/10,000th of the training of a physician, who shouldn't be doing these procedures. So be very careful. And
go ahead. I'm sorry.
And the final thing we talked about, make sure they're going to use some sort of imaging. I mean, muscular injections, tendons can be done very, very effectively with ultrasound, but anything in the spine, it's mandatory that you use C-arm. I mean, an X-ray machine. That's absolutely the standard of care.
So injecting with imaging, you got to ask them that. Make sure they're doing that, especially if it's low back, neck, or whatever.
Do not allow them to use an ultrasound in those structures.
It's just not clear enough.
It's not clear enough, and there are things that you can't see on ultrasound that you can on X-ray, and even if nothing bad happens, you can't be assured that you're in the right structure. Not with ultrasound, not in the spine. You can in a knee or a hip or a tendon. That's a fantastic way to do it, but don't go into the spine with an ultrasound. Don't let anybody do that.
Now, the other thing with going to an interventional pain management physician, because after all, I mean, you guys understand pain. You understand what causes pain. You understand how to move nerves out of the way or take pressure off nerves. So it's more than just the stem cells, because I'm sure you could teach me how to do, these PAs are doing, these physicians' assistants. You could teach me how to inject, I'm sure, stem cells, but it would take me another 20 years to learn what if something goes wrong, or how to treat the real underlying cause of this, rather than just putting a Band-Aid on the situation. So I think, do you have a bias? Do you think, if you're going to do this, that you should look for an interventional pain management trained physician?
Yes, I would say that we are probably the ones that have done more of this than most anybody else, other than there's some retired physicians that were early adapters, the forefathers of regenerative medicine. Some of them were family practice physicians with additional training. Some were surgeons, plastic surgeons. I know an OBGYN who got into this 15 years ago, and she's one of the preeminent people to go to in Florida. So there's some outliers, but right now, the vast majority of physicians performing these procedures are interventional pain physicians and radiologists, interventional radiologists.
Yeah, it's a shame. It's a shame in medicine, the way people are. They're saying, look, if insurance doesn't cover it, I'm not going to do it, right? But the fact of the matter is, to get some of these newer technologies, these newer methods, you just got to come up with cash out of your pocket, maybe $2,500 to $10,000, but it's more and more proven that it works. I hear nothing but stories of neck pain, back pain, shoulder pain, knees, people that were going to get surgeries. In my business, I hear all these anecdotal clinical stories of miracles, right? But I also don't get to hear the negative stuff, right? I'm only hearing the good outcomes.
And fortunately, there aren't that many negative outcomes. There are some big ones that caught national media attention, particularly that the intra-eye injections that were being done in California that blinded so many people. But the vast majority of bad outcomes are just nothing happens. But like I said earlier, there's this bioflare, and you've got to really understand what you're dealing with and have vast experience to have the judgment as to how to handle a potential complication. And I'll tell you that my colleagues that have done more than anybody else have seen these potential, infection of the disc. That's one of the dreaded things that we worry about. And it turns out it was bioflare. But having the maturity and experience to manage that saved the patients from having a really, really disfiguring or terrible operation, which sometimes you go in that particular case, an infected disc, you may have to go and remove the disc and flush out the area.
So that's happened.
It hasn't happened to my knowledge, but it could have happened if you didn't have a very experienced team of physicians who did the procedures, who were doing these research studies on these patients, managing them. And they knew, they were able to figure out that this was not an infectious process in numerous cases, that it was a bioflare. But had you had the wrong physicians, that weren't well trained, with that same scenario, that patient probably would have ended up with a significant, terrible operation, a fusion and lifelong pain afterwards.
And I guess, look, the judgment of the interventional pain doctor that's going to be giving you these growth factors, so-called stem cells, these solutions,
right?
Because I guess there's lots of companies in the game, lots of companies selling to doctors. So I'm sure that there are like the top 2 trusted, proven brands that you're using rather than the slightly cheaper brands that are unproven, or maybe
Right.
they don't have safety protocols that have been tested. So that a lot of that's going on as well, because this is a big topic, right?
Yeah, it's huge, and there's a lot of, unfortunately, unscrupulous companies out there, and basically brokers, for lack of a better term, that broker these products. They don't produce them. They're just great salesmen, and they broker them to physicians, and then they take their cut off of that, sometimes at pretty steep prices. So be careful, obviously. Ask your physician why they use what they use. Is it because a pretty young rep came in and was a sweet-talking salesman, or is it because they have a lot of good reason behind it? And I always tell patients why I use the 3 products that I use for different indications, and there are plus or minus 180, 190 different products out there, and there are 3 that I use. And there's reasons for that.
Okay, good.
Safety and efficacy. Yeah.
All right.
Randy, one other thing. You talked about expense. There are ways to fund this. Other than coming in with a check for $2,500, right? I mean, there are medical credit companies that will allow you to pay this off over a year or 2, or they finance it at very low rates. So they'll pay for you to have the procedure, and then you can pay it off over time.
Like I told you, I interviewed dentists on my show that are doing dental implants, and per arch could be anywhere from $17,000 to $35,000 per arch of teeth. It's routine that they're in your neighborhood $70,000 for an upper lower set of teeth. Now, you get a lot of value there out of being able to eat and chew whatever you want and smile and date and kiss and everything. But to me, $2,500, $3,000 as if you catch it early enough, it's worth the risk.
Absolutely.
And Warren Buffett says that risk is not knowing what you're doing. Right? You got to know the rules of the game. And one of the things with an interventional pain management physician, at least some of the things I've learned, I've spent probably a couple hundred hours listening to you guys, that you guys know the rules of the game. You at least know. That means if you want to minimize your risk, which is basically if you want to maximize your chances of getting a good result, then go to a person with a lot of experience and that's interventional pain management trained. That's how I feel.
And one of the biggest guys in the field is an interventional radiologist. But again, he has vast experience in doing these procedures. So I would say between those 2 fields, there's some orthopedic surgeons that do it, quite a few actually, but many of them don't have the experience using X-ray and doing the procedures like we do. So just, take that into consideration when you choose a physician to perform these procedures.
Okay, Dr. Ranson, I know people travel to see you. Is that right? You could get on a plane and go to Arizona and see you?
It's not a hard sell here in Scottsdale. It's a beautiful place.
Yeah. All right. So you kind of have a fly in, fly out. I mean, could they literally fly in? I mean, they're only spending about 3-4 hours with you?
I typically, if I'm going to do an intraspinal procedure, I like them to stay overnight. In a nice hotel or whatever, just to make sure that they're fine the next day. I usually see them the following morning, and then they go home, wherever that is, Canada, wherever. Yeah.
They go home with no pain, and they're excited, and they're, it's like Bosley Hair Club for Men. The guy gets his hair, and he's at Machu Picchu, and he's swimming, and he's partying. But that's truly what this does. That means if you feel better, if you're out of pain, you're more likely to do what you love to do in life, even if that's bowling, God forbid. I mean, so your program really helps people do more of what they love to do, even if that's walking the dog or going to Costco or whatever.
People ask me all the time, is this going to extend my life? I don't know. We haven't studied lifespan extension. It quite possibly could. But my goal, is to improve your quality of life. So I would like to see a world where when I'm 90, I still am able to do the things that I did when I'm 60, if that makes any sense. So
Okay.
Because I'm able to heal the joints. I'm able to prevent them from degenerating, right? So like we touched on earlier, prophylactic treatment before it becomes necessary to replace a joint. Intercede years earlier. And, and hopefully we can stop the progression of all these degenerative joint and spine disorders where you're 90 and you're still skiing.
Well, what you just talked me into? You don't even realize it. I almost feel like I want to go get imaged, whether it's an MRI. I've seen MRIs. I don't know how to read MRIs. But I look, and I'm sure certain discs are a little bit more squished together than others. I could just go in and say, let's inject my discs that are starting to show some wear and tear. Why not?
You could. Well, we tend to wait until you have a little bit of pain. Okay. Because there's risk benefit, right? So we want to make sure that it's actually somewhat symptomatic.
So we got to walk in holding our back, pretending like we're in pain in order to get this done.
You don't have, well, like I said earlier, my radiology friend, he's not in significant pain. It doesn't really affect his function, his level of activity, but it does a little bit. He knows it's there. He feels it. And so he wants to go in and treat this before it becomes a big deal.
And by the way, I wanted to ask you something you said earlier about some people get immediate relief in pain. Is it because maybe it's kind of shrinking the area or reducing inflammation, taking pressure off the nerve or whatever? Is there some of that going on?
Yeah, it's reducing the inflammatory cascade. We haven't seen, say, I can't say that the regenerative products cause resorption of disc that's protruding. Maybe they do. Maybe they accelerate it. Sometimes that happens, and that's what we hope for when we say your disc heals itself. That can happen over time, naturally. But what it does is it prevents, I think, my reasoning behind, or my theory is it's reducing the chances of fibrosis and scarring at that level, say when the disc pinches the nerve.
You know something. Somebody told me this. It was like, and maybe you could clear this up. It was like science fiction. He says, Randy, this is the way he compared it to a starfish. I mentioned it earlier. He said, with a bulging disc, some of the things they're doing in Germany and Cayman that we can't even do out here in America, that they're injecting the disc, this bulgy disc, and somehow the genetic code or whatever's happening, that somehow this disc could return to where it was supposed to be. And he says, we've seen it rare, and we don't even know the mechanism, but it's like seems to go back to where it was supposed to be.
We have theories about it. And like I said, that's the beauty of this product that we're using that's really a couple years old. We have now 224 patients over 12 months out and a much bigger population on this registry that we've started.
Okay.
And we're going to be tracking them with MRIs as well as all these other indices of return to function, reduction in pain, potential complications, which fortunately we haven't had any with this product. But these are things we're going to be looking at. So you don't need to go to Germany to have that done.
I got last question because we haven't talked about this. For the super high roller, whoever you are, banking your stem cells while you're young, you're in your 40s, you bank, and the stem cells that you're banking, are these going to be from what? Are they from marrow or what?
Well, I think moving forward, like my 8-year-old daughter and my 6-month-old son, their stem cells, their cord stem cells are banked. And the reason we did
When were you going to tell me this, doctor? You saved this for the end.
Yeah. I mean, and it's going to be kind of an ethical issue. So I know physicians who say, yeah, my kid's stem cells are banked, and God forbid I ever get leukemia. If they're a match, you could take a few of those cells and you could expand them. Probably not in this country yet. They'd get really, the FDA would probably come down on it. But you could take them down to Mexico, expand them, and then implant them and have a bone marrow transplant. The reason I bank my children's stem cells is, God forbid, they get cancer or some other unforeseen, later in life. So this generation, we weren't, privy to that as children. 40, 50 years ago, that wasn't available. It's really only been available about 15 years, to my knowledge, banking the stems of the cord blood, maybe 20. And even then, we didn't really know what we were going to do with it, right? We just kind of said, well, it's a good thing to save it. Now we have ideas what we could do with it. And it could be that my daughter or son, if he ever needed a heart transplant, in 60 years, they could grow one for him. Who knows?
Wow. Okay.
But once it's gone, it's gone. Our stem cells aren't very good anymore. I hate to say that. I like to call myself a spring chicken because I have young children. But the fact of the matter is, I'm way past 40, and my stem cells are not very good at doing their job anymore. And even after 30, even after 30 years old, you can see substantial reduction in stem cell activity as well as the growth factors in your bloodstream. I'll give you a little stat, and you can ask any other questions you have. But when you're a newborn, if you take your bone marrow, 1 out of every 10,000 cells in that bone marrow is a stem cell. In a teenager, it's 1 out of 100,000. And at 50 years old, it's 1 out of 400,000. You see the difference?
Yeah. Is that why we're babies, if they get an injury or whatever, that they heal much quicker? And also, even with coronavirus, which is topical, because could it be a relationship with the high levels of stem cells that the mothers don't pass it on to their children?
It's a really complex question. And we're seeing different syndromes in the children that we're seeing in adults. Although now there's evidence that they're getting that inflammatory cascade like the children were. But I think we always have this saying, and it's kind of brash, but it's hard to kill a kid, right? It really is, because they have unbelievable propensity to heal and regenerate tissue. They're still growing, and until you stop growing, and I'll tell you something my biochemistry professor told me when I was 18 years old, and I'm a freshman in college. He said, "How many of you are still growing?" I was squeaking out an extra half an inch then, so I raised my hand, and maybe four or five other men in the class raised their hand. And he said, "Well, this doesn't apply to you yet, but it will in a year or two. The rest of you are dying. The minute you stop growing, you start the slow process of death, which is aging, right?" And so I think, the children, kids who are still growing, they haven't started the process of aging, and they're just a completely different physiological state than you and I are.
It's like my endocrinologist, Schwarzbein. She told me a long time ago. She said, as you're at about age 24, 25, up until then, you're rebuilding faster than you're breaking down. And that goes for collagen and elastin and everything else. And then at about 27, 28, now you're breaking down faster than you're rebuilding. So that's why they're tricking now the system with adding, heating the underlying tissues for faces, microneedling. So the body now is forcing. It's kind of like doing what the 18-year-old was doing, which is repairing itself and adding more collagen. So it's the same thing, it sounds like, with stem cells, that eventually you're going to see more and more people that are going to take advantage of this modern medicine.
Absolutely. I mean, the cosmetic applications, other than hair restorations you touched on,
my hair is from stem cells. I've never had any plugs or anything or transplant, but my hair grew back with stem cells, two treatments.
It's amazing. Yeah.
It really is.
It is. I use it in women. Something I didn't know about until a few years ago is that, postmenopausal women, gosh, I think, the vast majority of them have some hair loss, and many of them have profound hair loss. And I never really thought about women as suffering. You see people with alopecia, but you think, well, maybe they had chemotherapy or something. I never really thought about it until I got into this field. And it's something that affects men and women both. And I had no idea until a few years ago that women were as affected as they are by hair loss. And it responds, just like men, to growth factor treatment.
I don't know if this is true, but the hunch of Dr. DeYarman, who's been doing this for 40 years, one of the longest standing hair transplant guys in the world. And he goes, "Randy, if you come and see me once a year, I'm convinced you'll never go bald." He goes, "I can't prove it yet because it hasn't been around long enough." And my son, who's 28, has cue balls on both sides of the family, father's side, mother's side. They're all bald. And now he's getting treatments, and it's totally making a difference. So anyway.
And that's important. You mentioned that he's doing it now rather than later, because I think the earlier you intercede with hair restoration, just like everything else, the better the outcome. If you've got no hair at all on top, there's really nothing, no hair roots.
Yeah, once it sinks in that hole, you're done.
Yeah, once you get to a certain point, the chances of meaningful regrowth are low. Okay, I'll put it that way.
But every woman knows this too, that once they get a certain age, let's say 50. Their hair they have to have extensions because their hair doesn't grow long anymore. It's done. In fact, even with me, the front of I'd have to go in and only the back was growing. Guys understand this over 50, and the front hardly grows. Well, now that the stem cells, now my front is growing. And the women now are telling this guy, and I've talked to one of them, I've interviewed him, that now all of a sudden their hair grows again, where it just stopped growing and they don't need extensions.
I treated a woman recently that's she's 70, but she looks like she's in her 50s. She's had a lot of stuff done, and she's a very prominent businesswoman. She's still very, very active in business and consulting. And she had, and women will understand this better than you and I do, but she had 27 extensions for hair loss and for the fact that her hair just wouldn't grow. 3 treatments, 1 a month, and then I did some laser light therapy as well, and intermittently. To help regrow some of the blood vessels in the scalp. And she was down after her second treatment to 9 extensions, and by her third treatment, they were removing all the extensions. And substantial regrowth of hair.
It's
One of
big.
the other interesting, and it gets thick, and it grows like a 20-year-old's. And one of the interesting things we've seen, not every time, but sometimes people with a lot of white hair, it actually turns the hair back into its native color. Because
I don't dye my hair, and it looks, I'm half Mexican, but my hair is black, and I have really no gray. I had a few grays, and come to think of it, they're really almost disappeared.
It's from the therapy. I think it's basically turning your follicle back into its native state. And that's why you see the hair restoration. If the follicles aren't completely gone, then you can see meaningful growth. And it may grow back black or whatever color your native state is.
All right, good. Well, we're going to load ourselves up with stem cells here in the future, or growth factors, or regenerative therapies. Anyway,
Stick with products, yeah.
Dr. Ranson, I want to thank you for coming on the show. Good stuff. If somebody wants to find you, what do? They go to what website?
Well, I mean, I have several, but you can just Google. Right now, my company is Gateway Anesthesia and Pain Associates, and then we have a regenerative clinic as well associated with that. But it's in the primary clinics in Mesa, Arizona, and then I have another one in Paradise Valley, Arizona.
Okay,
which
good.
is the Scottsdale area. Yeah.
All right. Well, Dr. Ranson, it was a pleasure having you on this podcast. And
All
all right, I'll see you later. Thanks for coming on.
Thank
All
you.
right.